Pericardial effusion. Etiology, pathophysiology, and pathology. Pericardial effusion may develop in cases of acute pericarditis from any cause. The normal pericardial space contains 1550 ml fluid and can only accommodate a rapid increase in pericardial volume to 150-200 ml before the intrapericardial pressure starts to rise. Once intrapericardial pressure exceeds intracardiac pressure, left ventricular filling and cardiac output decline. With a gradual accumulation of fluid, volumes of up to 2 L may be present before left ventricular filling becomes compromised. Acute cardiac tamponade typically follows cardiac trauma, which may be iatrogenic, aortic dissection, spontaneous bleeding, or cardiac rupture after a myocardial infarction. Chronic tamponade usually results from malignancy, idiopathic pericarditis, or uremia, although almost any cause of acute pericarditis may be responsible. Clinical presentation. Common. In chronic cases, the patient may be asymptomatic despite a large effusion. Typical symptoms include shortness of breath and mild chest discomfort. Uncommon. In a large pericardial effusion without tamponade, compression of adjacent structures may lead to the following: dysphagia, esophagus, cough, bronchus or trachea, hiccups, phrenic nerve, hoarseness, laryngeal nerve, abdominal bloating and nausea, abdominal viscera. Physical signs. In most patients, the examination will be normal. In large effusions without tamponade, there may be muffled heart sounds, crackles, compression of lung parenchyma, or Hewitt's sign, patch of dullness below the angle of the left scapula caused by compression of the base of the left lung. There may also be pericardial friction rub or signs of cardiac tamponade. Cardiac tamponade should be suspected in a shocked patient with apparent clear lung fields and elevated JVP. NB. Cardiac tamponade may present in 3 ways. Cardiac arrest. A severely ill patient who is stuporous or agitated and restless, survivor of acute tamponade. With dyspnea, chest pain, weight loss, anorexia, and weakness, more slowly developing tamponade. Rapid recognition of the clinical signs of tamponade is essential. Tachypnoea and tachycardia. Pulsus paradoxus. Pulse becomes impalpable on inspiration in severe cases. Elevated JVP with prominent systolic X descent and absence of diastolic Y descent. Rarely, normal JVP in severe dehydration. If you suspect the diagnosis, organize an urgent echocardiogram. Investigations. ECG. This is usually normal, although changes of acute pericarditis may be present. There may be a nonspecific reduction in QRS voltage and T-wave flattening. Electrical alternans is suggestive of a large effusion. Chest radiograph. This is often normal, although a large effusion may cause an enlarged globular cardiac silhouette with clear lung fields. Look for separation of the pericardial fat lines in a left-sided pleural effusion, Fig 61. Echocardiography. Echocardiography is the most sensitive test for detection of pericardial fluid, as little as 20 ml. This appears as an echo-free space around the heart, Fig 61b. Diastolic left and right heart collapse. Marked decrease in mitral inflow with inspiration and a dilated inferior vena cava that fails to collapse with inspiration suggest tamponade. Differential diagnosis. In chronic cases, consider the following: constrictive pericarditis, restrictive cardiomyopathy. In those with tamponade, consider causes of circulatory collapse, in particular massive pulmonary embolus and severe asthma. Treatment. Consider the following. Urgent pericardiocentesis is essential in cardiac tamponade. It is also needed for diagnosis if there is suspicion of purulent or tuberculous pericarditis, or prolonged and otherwise unexplained illness. Symptom relief as for acute pericarditis. Recurrent or persistent symptomatic effusions may require balloon pericardiostomy or surgical pericardiectomy. Complications. Common. Complications arise more commonly from the underlying condition than from the effusion, although chronic pericardial effusion lasting more than 6 months may be seen. This is more likely after idiopathic, uremic, myxodematous, or malignant pericarditis. Uncommon. Uncommon complications are cardiac tamponade and constrictive pericarditis.